All right, let's jump right in. Today, we're unpacking one of the absolute most vital, high-stakes procedures in emergency medicine, establishing a patent and protected airway. Specifically, we're zeroing in on a genuinely brilliant piece of life-saving medical tech, the iGel Supraglottic Airway. Look, if you're a first responder or a medical pro, you already know that seconds literally dictate survival. Understanding the precise mechanics of the tools in your kit is absolutely crucial. So in this explainer, we're going to break down the exact protocols, the wild engineering behind this device, and that step-by-step dance you need to use it flawlessly out in the field.
Picture this scenario. You arrive on the scene, and your patient is completely unresponsive. They can't maintain their own airway, and that vital flow of oxygen, it's just stopped. You test for gag reflex, nothing. Time isn't just ticking at this point, it's practically evaporating. So how do you establish a secure, protected airway instantly so you can actually get effective ventilation going before permanent damage sets in? Well, that is the exact life-or-death crisis we're solving today.
Here is our quick flight plan for today. We're going to cover the airway crisis, meet the iGel, patient preparation, the insertion technique, and finally, securing the airway. Let's get to it.
Okay, Section 1, the airway crisis, establishing the rules of engagement.
Like any medical procedure, no matter how urgent it is, you've got to have strict boundaries before you take action. The crucial thing here is knowing exactly who this device is actually for. The iGel is indicated for patients who are unresponsive, unable to protect their airway, and honestly, unlikely to wake up anytime soon. The absolute defining factor? The absence of a gag reflex. But on the flip side, we've got our strict contraindications, our absolute no-goes. You do not use this device if the patient has trismus, that severe jaw clenching where you just can't open the mouth. You also skip it if they have an intact gag reflex or if the airway is just completely inaccessible because of an obstruction or severe trauma.
Even when you get the green light, there are always risks, right? You got to keep an eye out for gastric distension, which is when air gets pushed into the stomach during ventilation. If you accidentally stimulate that gag reflex, you're risking vomiting, which is a massive mess. And remember, precision is everything here. If you use too much four-string insertion, you can easily cause soft tissue injury to those delicate airway structures, or even crack a tooth. You're there to save a life, so avoiding any secondary trauma during the chaos is paramount.
Moving right along, Section 2. Meet the iGel, the anatomy of a lifesaver.
Let's take a closer look at the actual engineering of our chosen weapon for this crisis. What makes the iGel so brilliant is how its physical design just totally removes the standard points of failure. Take the non-inflatable cuff at the bottom. In the older devices, you'd have to insert a tube and then manually pump a balloon to get a seal. By ditching the need for cuff inflation altogether, the iGel makes insertion incredibly fast and super easy. Just above that, there's the epiglottic rest. This little feature is a game changer because it stops the epiglottis from folding down and blocking the airway. Plus, it has a gastric channel to handle any regurgitant fluid, a buccal cavity stabilizer so it doesn't spin around, and get this, an integral bite block built directly into the stem. That way, if the patient's jaw suddenly clenches later, the airway won't occlude. It's honestly just elegantly simple.
And that elegant simplicity? It totally extends to how you actually select the device. In a true emergency, responders do not have time to sit around guessing or squinting at fine print in the dark. That's exactly why these things are brightly color-coded. You pull it out of the jump bag and you instantly know what you've got.
The sizing math you need to memorize is totally based on the patient's weight. So, if you've got a small adult, somewhere between 30 and 60 kilograms, you're grabbing a size 3, which is the yellow one. For a medium adult, say 50 to 90 kilograms, you need a size 4, that's green. And for a large adult over 90 kilograms, you're looking for a size 5, the orange device. It's a rapid visual cue that saves absolutely crucial seconds when it hits the fan.
Okay, on to Section 3, patient preparation, setting the stage.
This is where the physical response actually kicks into gear. Before you even think about inserting the advanced airway, you have got to maximize the patient's oxygen reserve. Start off by applying your standard BSI precautions. Always ensure scene safety first. Then immediately open the airway using a head tilt chin lift, or, a jaw thrust if you're suspecting trauma, and clear out any gunk or obstructions. Once it's clear, drop in an OPA, an oral pharyngeal airway, and start bagging them. Ventilate with a bag valve mask, or BVM, crank to 100% oxygen. Make sure you've got a rock-solid mask seal and you're seeing good chest rise. At this exact point, your partner takes over those ventilations. They'll maintain a rate of about 1 breath every 5 to 6 seconds for adults, keeping this pre-oxygenation phase going for about 2 solid minutes.
Now for Section 4, the insertion technique, what I like to call the 14-step dance.
We are now entering the critical execution phase. While your partner is busy ventilating, you select the correct weight-based size, carefully pop it out of its protective cradle, and give it a quick visual check for any defects. Next up, grab your water-soluble lubricant and apply it to the back, the sides, and the front of the cuff. But listen, here's a massive warning. Do not over-lubricate this thing. Seriously, excess gel can actually blob up and cause an airway obstruction, defeating the whole purpose. Once it's prepped, your partner pulls the OPA out while you position the patient's head. For most adults, you're aiming for that classic sniffing position. But if there's any suspicion of a cervical spine injury, you've got to keep that head perfectly neutral.
Think about what we're actually trying to achieve inside the body here. The iGel is designed to follow the natural curve of the airway. It basically just glides right along the hard palate until that gel-like cuff seats itself flawlessly over the laryngeal framework. It ends up right above the vocal cords, effectively sealing the entire airway without needing a single pump of air for a balloon.
So, to get it seated properly, you open the mouth using a tongue jaw lift or scissoring technique. You hold the iGel almost like you'd hold a pen, and you insert the device straight back. Not upward, straight back. Do it in one continuous, fluid motion, letting it glide gently along the palate. You're going to naturally feel resistance when the patient's incisors come to rest directly on that built-in bite block, right at the indicator mark. Do not force it past that point. The moment you begin ventilating through it, your partner has to immediately step in to confirm placement and hunt for air leaks. They're listening for hissing sounds around the mouth, checking for poor chest rise, and if needed, you might have to tweak the positioning just the tiny bit.
I really want to pause on this placement confirmation for a second, because your partner's role here is make or break. They are listening with their stethoscope for two totally opposite things. First, they check for epigastric sounds right over the stomach. This needs to be absolutely negative, absent, nothing. If you hear gurgling down there, bad news. It means you're inflating the stomach, not the lungs. Second, they jump up to listen for lung sounds. These should be strong, present, and equal bilaterally. That's how you know for sure that our lifeline is exactly where it needs to be.
Almost there. Section 5, securing the airway, the golden rule.
All right, the tube is in, the patient is finally getting oxygen. But guys, the crisis is not over until this device is fully locked down. This brings us to a warning so incredibly important, it is literally written in all capital letters in the protocol. Do not let go of the iGel until it is secured. Seriously, accidental displacement at this stage completely undoes all your hard work and puts your patient right back in mortal danger. As the primary responder who just inserted it, you have to maintain a steady, unyielding, physical death grip on that device while your partner takes over the bagging. So, for this final phase, you keep that unyielding grip while applying a commercial airway tube holder to secure the iGel. As you fasten the holder, you actually want to maintain just a slight bit of inward pressure. This makes sure the device stays at the perfect depth and doesn't try to migrate outward. Once, and I mean only once, it is fully 100% secured, you resume those continuous ventilations at the appropriate rate. Again, that's one breath every 5 to 6 seconds, making absolutely sure you're getting adequate chest rise and continuous 100% oxygen delivery.
We have covered a massive amount of ground today, from the weight-based color coding all the way through the insertion sequence, and it leaves us with a really powerful thought to chew on. How does simple, cuffless engineering, when combined with absolute strict procedural discipline, completely change the face of modern emergency resuscitation? Well, it removes the guesswork. It takes an incredibly complex, chaotic internal physiological crisis and turns it into a manageable, reproducible protocol. When hands-on training meets this kind of hyper-thoughtful medical design, first responders are empowered to literally secure a lifeline in seconds. Thanks so much for joining me on this explainer. Keep learning, stay focused, and I'll catch you next time.